In this lecture, we will be discussing the surgical approaches to intracranial aneurysms. Basic tenets of cerebrovascular surgery. Most aneurysms are deep within the CSF cisterns and require extensive subarachnoid dissection. These aneurysms are typically in the deep subarachnoid space, and they reside in the deep crevices of these cisterns. And it's important that we consider the dissection and maneuverability within the subarachnoid space. In particular, subarachnoid hemorrhage can make aneurysm surgery difficult because of the presence of hemorrhagic byproducts, inflammatory reactions, fibrinous adhesions, and edema that can render the brain resistant to easy manipulation. It is therefore very important to optimize the conditions of the brain to make aneurysm surgery as painless as possible. For instance, it is important to optimize operative conditions and to minimize retraction. This includes treating hydrocephalus before the craniotomy. The treatment of hydrocephalus can provide sufficient brain relaxation, and this can be done through CSF diversion, such as a ventriculostomy or lumbar drain, and also cistern fenestration. Hypertonic solutions, metabolic suppressive agents such as thiopental or propofol can also aid in brain relaxation. Positioning can also improve brain swelling, for example, elevating the patient's head and ensuring adequate cervical venous drainage can be accomplished, as well as hyperventilating the patient. Next, it is important to consider and accomplish proximal and distal control of the aneurysm. Securing control of blood flow both proximally and distally to the aneurysm can prevent a devastating hemorrhage in the event of an intraoperative rupture. It can also soften the aneurysm and aid in perianeurysmal dissection and eventual clip placement. Further on proximal and distal control, in many aneurysms of the anterior circulation, proximal and distal control can be accomplished relatively simply by dissection of the parent artery proximal and distal to the aneurysm in question, and placement of a temporary clip at both locations. These temporary clips have a less aggressive closing force than permanent clips, and this prevents damage to or dissection of the artery being clipped. However, sometimes proximal control of the parent vessel may not be practical because of bony anatomy or other anatomy that obscures the proximal portion of the parent vessel. And in these cases, there are alternative techniques that can be utilized to decrease the blood flow to the aneurysm. An example of difficulty obtaining proximal control for a particular aneurysm is obtaining proximal control for proximal intracranial internal carotid artery aneurysms. And these are difficult to obtain proximal control due to the bony anatomy surrounding the proximal portion of the intracranial ICA. In this particular example, exposure of the cervical ICA in the neck is often recommended, and in the event of an intraoperative rupture, a temporary clip can be placed on the cervical ICA. Additionally, proximal control can be achieved through manual compression of a cervical ICA by an assistant or someone outside of the operative field. Lastly, if proximal control cannot be secured through an intracranial or extracranial route. For example, in the case of aneurysms of the proximal basilar artery, adenosine-induced bradycardia and hypotension may prevent a catastrophic hemorrhage and provide enough proximal control to allow for effective dissection and clipping. There are many cranial approaches to intracranial aneurysms that provide access to different portions of the skull base and intracranial circulation from various angles. The majority of intracranial aneurysms can be approached and treated with the use of minimal number of cranial approaches, and each approach can be modified in different ways to suit the surgeon or to suit the aneurysm that's being treated. There are 6 common cranial approaches that form the foundation of the majority of surgical interventions for cerebrovascular disease, and we will describe each of them in the following slides. The pterional craniotomy, or the frontotemporal craniotomy, may be used to access most aneurysms of the anterior circulation, including those of the intracranial ICA, MCA, posterior communicating artery, and most anterior communicating artery aneurysms. There is a modification known as the anterior fossa intradural craniotomy approach, and this extends the craniotomy medially along the orbital roof to the supraorbital notch, and also prevents retraction and provides better circumferential aneurysm exposure. In terms of positioning, the patient is placed supine with a shoulder roll under the ipsilateral shoulder. The head is placed in the Mayfield 3-point pin fixation device, and the head is turned or rotated 10 to 45 degrees to the contralateral side, and then is translated anteriorly. The closer the aneurysm lies to the midline, the less contralateral rotation is typically required. The vertex is then rotated 10 to 20 degrees towards the floor, and the malar eminence is typically at the highest point of the operative field, which allows gravity to pull the frontal and temporal lobes away from the sylvian fissure, so that less frontal and temporal lobe retraction is necessary. During exposure and during the craniotomy, it is important to preserve the superficial temporal artery, and it's also important to be cautious of the large frontal sinus. There are various techniques by which the temporalis muscle may be incised, mobilized, and retracted, and each has its own virtues and limitations. In the myocutaneous flap, both scalp and temporalis muscle may be elevated as one unit, and both are reflected anteriorly. This ensures safety of the frontalis branch of the facial nerve, but it can lead to bulkiness of the temporalis muscle itself, which can limit visualization along the sphenoid ridge. The submuscular dissection approach can also be used, which improves visualization, but there is increased risk of facial nerve injury, and this approach is cosmetically undesirable due to temporal muscle wasting. In the subfascial dissection approach, the temporalis fascia is incised at the posteriormost aspect of the incision, and the temporalis fascia, including both superficial and deep layers, along with the suprafascial subgaleal fat pad, are elevated together along with the skin flap, and these are reflected anteriorly. In the interfascial dissection approach, the scalp is dissected free of the temporalis fascia, as in the submuscular dissection, but in this particular method, the superficial layer of the temporalis fascia and suprafascial or subgaleal fat pad are dissected together from the deep layer of the temporalis fascia. The superficial layer and fat pads are elevated together and reflected anteriorly with the scalp flap, and the deep temporalis fascial layer and temporalis muscle are incised at their attachments and reflected in a variety of directions. This particular approach improves visualization and dissection within the cranial vault, but it has been criticized for being complicated. The pterional craniotomy is traditionally begun with a single burr hole in the temporal bone near the root of the zygoma. Some surgeons also prefer a single burr hole near the pterion or the keyhole, and other surgeons prefer to perform multiple burr holes. This is in particular the case in patients of advanced age in whom the dura becomes more frequently attenuated and can be adherent to the inner lining of the bone. During the craniotomy, often the craniotome encounters difficulty traversing the sphenoid ridge. The surgeon can perform this portion of the craniotomy by drilling a trough of bone in this location to a paper-thin thickness with a high-speed drill, so that when the bone flap is finally elevated, this bony trough fractures without difficulty or fragmentation. In particular, when performing the anterior fossa intradural craniotomy, the surgeon can drill the sphenoid ridge as far as the lateral aspect of the superior orbital fissure. Depending on the location of the aneurysm treated, further extradural bone work might involve removal of the anterior clinoid process for some proximal ICA aneurysms, for example, or the optic strut, or both. After the craniotomy, the dura is opened in a C-shaped manner and reflected anteriorly. The frontal lobe is then retracted slightly, and the carotid, chiasmatic, and lamina terminalis cisterns are incised to release cerebrospinal fluid. This provides relaxation of the brain and facilitates further dissection. The surgeon then dissects the sylvian fissure, often beginning with the opening of the sylvian cistern arachnoid near the opercular frontal gyrus, medial to the sylvian venous complex. Further dissection is then tailored to the specific aneurysm being treated in each case. The orbital zygomatic approach, or OZ craniotomy, is a variation of the traditional pterional craniotomy that provides improved exposure to and maneuverability around the orbital apex, basilar apex, paraclinoid and paracellar regions, the cavernous sinus, the upper third of the clivus, and the floor of the anterior and middle cranial fossa. This is especially important for aneurysms of the basilar apex and giant or otherwise complex aneurysms of the anterior circulation. The removal of the orbitozygomatic complex is the only difference between the OZ approach and the anterior fossa intradural craniotomy seen in the pterional approach. This extra removal of bone allows a deeper skull base approach and is particularly important in high-riding aneurysms of the basilar tip and large posterior pointing aneurysms of the anterior communicating artery. This inferior bone removal allows a surgeon to look more superiorly by angling the surgical trajectory from a more inferior position. In the OZ approach, the orbitozygomatic unit is removed via a series of 6 osteotomies. These osteotomies are performed with a reciprocating saw or osteotome. The first cut divides the zygoma obliquely at its root. The second and third cuts divide the zygomatic bone above the malar eminence. The fourth osteotomy is made in the sagittal plane through the medial orbital roof just lateral to the supraorbital notch. The fifth cut traverses the posterolateral orbital roof in a medial to lateral direction, approximately 2 to 3 centimeters posterior to the inner table of the frontal bone, ending laterally in the sphenoid ridge. The final cut divides the lateral orbital wall from the inferior orbital fissure to the point of the fifth cut in the sphenoid ridge. After these osteotomies, the orbital zygomatic unit is removed in block. The anterior interhemispheric approach allows access to aneurysms of the pericallosal artery, which is a branch of the anterior cerebral artery. An approach from the right side of the falx is frequently preferred, regardless of the laterality of the aneurysm, in order to avoid retraction or manipulation of the dominant hemisphere. Less frequently, the anterior interhemispheric approach can be used for aneurysms of the anterior communicating artery, and specifically in aneurysms for which a combined A2 to A2 segment bypass will be required, or in those that point posteriorly or superiorly. Patient head positioning differs slightly depending on the location of the pericallosal artery aneurysm. For both proximal and distal pericallosal artery aneurysms, the patient is placed supine, but the head is often in a neutral position with the neck slightly extended for proximal pericallosal artery aneurysms, whereas the head is typically turned 90 degrees to the right for aneurysms of the distal pericallosal artery to allow gravity to aid in retraction of the right hemisphere. A right bicoronal incision is often used, beginning at the root of the zygoma on the right and extending to the left superior temporal line. For aneurysms of the distal pericallosal artery, a horseshoe incision may be preferable. During the incisions, the surgeon must carefully avoid violating the pericranium because harvesting a pericranial graft may be necessary to repair any frontal sinus defects that may occur. Exposure of the superior sagittal sinus allows the dura to be opened and reflected immediately adjacent to the sinus, which improves visualization of and manipulation within the interhemispheric fissure without the impediment of the overlying bone. The superior sagittal sinus and excessive bleeding from emissary veins must be avoided during the craniotomy. In older patients or those with attenuated dura adherent to the overlying inner table of the bone, it may be preferable to bisect the bone flap immediately to the right of the sagittal sinus, after which the sagittal sinus dura may be dissected free of the overlying bone under direct visualization before the bone flap that overlies the sinus is elevated. The dura is opened in a semicircular manner and flapped toward the superior sagittal sinus. It is important that the surgeon preserve any bridging veins, particularly those that are large and situated posteriorly. Dissection is carried down in the interhemispheric fissure deep to the falx until both pericallosal arteries are reached. The majority of pericallosal artery aneurysms are located 1 to 2 centimeters anterior to the section of the pericallosal artery initially encountered, and thus dissection is carried anteriorly along the artery until the aneurysm is visualized. For aneurysms of the peripeduncular segments of the posterior cerebral artery and the superior cerebellar artery, as well as giant, complex, posteriorly projecting or low-lying aneurysms of the basilar artery, the subtemporal approach may be necessary for improved access. In terms of positioning, the patient is typically placed in the park bench position. The patient's head is positioned with the sagittal sinus parallel to the floor and the vertex rotated slightly toward the floor. The skin incision is linear and perpendicular to the zygoma, being easily converted to the frontal temporal or posterior temporal flap if needed. For the subtemporal craniotomy, certain modifications may be required in order to provide better exposure and maneuverability. Particularly low-lying aneurysms of the basilar artery may be difficult to visualize or ligate via the standard subtemporal approach. In these cases, some surgeons advocate for partial tentorial section. Others retract the tentorial edge by suturing it to the dura of the middle cranial fossa. In other cases, a combined infratentorial, supratentorial approach may be required through the addition of a small lateral suboccipital craniotomy to adequately expose the pathologic entity being treated, particularly if it is lying at or below the inferior third of the clivus. Many aneurysms of the vertebrobasilar circulation originating proximal to the superior cerebellar arteries may be reached via the far lateral craniotomy. This is also known as a lateral suboccipital approach, extreme lateral approach, or extreme lateral inferior transcondylar approach. In this approach, bone is removed laterally, just medial to the mastoid area, and a corridor is created along the medial aspect of the petrous bone, and this allows for visualization of the vertebral and basilar trunks without retraction of the cerebellum. In the far lateral craniotomy, the patient may be placed in the sitting position. Alternatively, the patient may be placed in a 3/4 prone or modified park bench position with the ipsilateral shoulder being upward. Placing the patient in the lateral position minimizes the known risks of the sitting position, such as venous air embolism, and also minimizes brachial plexus compression and allows for greater venous return in comparison with the full prone position. With this position, the ipsilateral mastoid bone is at the highest point of the operative field. The ipsilateral shoulder is often pulled toward the feet and taped in this position, which prevents the shoulder from cramping the surgeon's space in the cervical suboccipital angle. In the far lateral craniotomy, an upside-down hockey stick incision is often preferred, beginning in the midline over the mid-cervical spine and extending superiorly past the inion, where it curves laterally parallel to the superior nuchal line and then inferiorly, terminating at the mastoid tip. Tissue dissection is carried through the paraspinous musculature in the midline, cervical, avascular plane. This dissection exposes the occipital bone, the foramen magnum, C1 lamina, and C2 spinous process. The vertebral artery may also be identified as it leaves the transverse foramen of the C1 lateral mass and courses along the C1 vertebral arch to enter the dura. A C1 laminotomy is optional, and not all surgeons remove this bone. For higher riding aneurysms, a C1 laminotomy may not be necessary. A suboccipital craniotomy is then performed after the foramen magnum is separated from the underlying dura with hand tools. The craniotomy should stretch from the midline foramen magnum superiorly to the superior nuchal line and transverse sinus, and laterally to the asterion and the underlying transverse sigmoid junction, and then return inferiorly to the lateral aspect of the foramen magnum. The lateralmost aspect of the foramen magnum and the posteromedial 2/3 of the occipital condyle are drilled. This removal should extend anteriorly to the condylar emissary vein, which produces a tangential epidural view of the dura as it begins to curve anteromedially toward the clivus and basion. The dural opening begins in the cervical midline beneath C1 and courses superiorly and then laterally, terminating at the superior-lateralmost aspect of the craniotomy. Cerebrospinal fluid drainage is often recommended before the dural incision is completed. Aneurysms of the basilar trunk are at a higher risk for rupture than are aneurysms at other locations, and securing the aneurysms, especially large aneurysms, is thus generally recommended. The trans-Petrus approach allows visualization of the basilar artery, the anterior portion of the brainstem, and the cerebellopontine angle. This approach includes an intradural subtemporal craniotomy, a pre-sigmoid craniotomy, and, on occasion, an added posterior fossa craniotomy. During the craniotomy, a temporal occipital bone flap is created with burr holes flanking the sinus and is extended anteriorly on the floor of the middle fossa. The surgeon performs a mastoidectomy and skeletonization of the sigmoid sinus to the jugular bulb, which exposes the sinodural angle and pre-sigmoid dura.
So this is a lady that was 68-year-old who presented with left-sided swelling in the neck and then was evaluated, and she was found to have an incidental anterocommunicating artery aneurysm that filled only from the left-hand side, with both A2s filling from the left side. She had a history of hypertension, cigarette smoking. Both her son and her grandfather died from ruptured aneurysms, therefore had a strong family history, and also had found an enlarged cervical lymph node, which turned out to be negative. With a cyst and an 8 mm anterocommunicating artery aneurysm, the decision to treat was easy, and I would strongly recommend treatment with this medical history. The aneurysm was 8 by 6 millimeters. It also was slightly irregular, and as I mentioned earlier, it filled from the left-hand side from a dominant left A1, and there was no filling from the right A1, and therefore we approached it through a left-sided anterofossa intradural craniotomy. The angiogram and the 3D ray confirms what we mentioned earlier. Fills from the left side, single left A1, both A2s from that left side, and a large neck aneurysm that was slightly irregular with multi-lobes, and therefore decision to treat. We decided on a left-sided approach because it falls from the left-hand side. My standard approach for aneurysms is what I call an anterofossa intradural approach, which is much like a pterional craniotomy, except that extended more further anterior to allow for a more subfrontal approach and less brain retraction. So this is the approach, which is the pterional approach with an extension, a frontal extension, and I call this a anterofossa intradural approach. I drill the floor of the anterofossa flush down with the M8 drill and extradurally, and then we come intradurally, and that allows for much less brain retraction and far better exposure of the brain.
So here I'm releasing some spinal fluid from opening up the arachnoid over the optic nerve. Now separating the arachnoid, finding the aneurysm after I'd found the ipsilateral A1. I think it's extremely important to circumferentially visualize all the aneurysms and its branches, and as I'm doing now, I'm separating the aneurysm from the surrounding brain, clearly delineating the A1, A2, and both A2s. We just placed a temporary clip on the ipsilateral A1 to allow for better exposure. I am now doing a clip reconstruction, placing my first fenestrated clip over the ipsilateral A1 and over the aneurysm dome. This will allow me to what I call manage the aneurysm and then apply further clips to completely exclude the aneurysm from the circulation. As we can see now, I can still see filling of the contralateral A2 that fills well, and I'm now placing a second fenestrated clip over the aneurysm and over the ipsilateral A1, excluding more of the aneurysm from the circulation. I'm now expecting it, and before I put my final clip on, I do check with Doppler to make sure that the filling occurs in both the contralateral A2 and the A1s, and to make sure we are good to go for the final clip application. I now place my final clip after visualizing all the surrounding vessels, which will exclude the aneurysm completely from the circulation, but provide flow through all the parent vessels as well as the branches. The final step is removing of the temporary clip, and now visually inspecting this aneurysm, which was a complicated aneurysm with a very broad base and incorporation of both the A2s and the communicator.
The patient did well. She was clinically intact. The things you're always concerned about in this area is a recurrent aortohumeral stroke, but she never had that. I'm very careful in the OR, and she went home on day 2.